So welcome to episode 27, where we're going to review the paper that's just gone by, which is the 2022A paper. And the way that I'm going to run this is I'm going to have a look at each question, and we're going to see whether each one is a repeat, a new question, or a variation of a previously repeated question. And then I've got a traffic light system to talk about the level of difficulty. So that green would be considered a repeat with a pass rate of more than 40%. A yellow would be a variation or repeat with a pass rate between 20 to 40%. And the red would be the hardest. So the red are new questions or a repeat question with a pass rate of less than 20%. And also what I'm going to do is I'm going to tie in those questions to a learning objective. So question number one was classify anti-emetic drugs according to their mechanism of action, give examples and describe side effects of each class. And this would be a green question. And the reason for that, it was a repeat from 2005, where it had a 65% pass rate. The variations of this question were repeated in both 2016 and 2015. So 2016, the variation was briefly describe the pharmacodynamics of agents used in the treatment of PONV with particular reference to their site of action and side effects. And then 2015 is describe the sites of actions of anti-emetic agents used for post-operative nausea and vomiting. So you can see that you don't have to go back as far as 2005 to actually cover this question. And it's got a very good pass rate. And the learning objective, the primary learning objective is BTGS 1.44, describe the clinical pharmacology of dopamine antagonists, anticholinergic agents, serotonin antagonists, antihistamines, prokinetics, and steroids relevant to pre-medication and the management of nausea and vomiting. And essentially, this will give you your core answer, although there are some other classes that you should also list and name. And then the secondary learning objectives, they would be understanding about the physiological basis of vomiting and also discuss the prevention and management of post-op nausea and vomiting and outline the pharmacology of drugs acting via effects on serotonin. Must be noradrenergic receptors. Apologies about that. That's probably a typo here. So effects on serotonin or noradrenergic receptors. Now I'm just going to show you a candidate. So a candidate has kindly given permission for me to sort of publish this. This is their 1 minute structure for this answer here. And let's have a look at it. So they've drawn a diagram, and this is a diagram that I'll sort of, I think I've created previously for one of my short answer questions in that in the 1 minute drill. So I do a triangle that surrounds the vomiting center, and then on top you've got the cortex. On each side you've got the nucleus tractus solitarius and the chemotrigger receptor zone. You've got the receptors associated at each site. Going into the nucleus tractus solitarius, you've got the gut, and the candidate has also put the CVS as well, which is good. And going into the chemotrigger receptor zone, you've got the vestibular, okay, which he has here. Interestingly, he's also going to be dividing it into both antagonist and agonist, although most of the drugs that are antiemetics would be antagonists, and I guess the only one would probably be a little bit unknown, but perhaps Maxlon and its peripheral effects through 5-HT4 agonism. Okay, that would be one, I would think. But otherwise, yeah, this is a very sort of good 1 minute structure or key objectives in terms of knowing what they're going to write for this answer here. Now, question number 2, describe the factors determining transdermal uptake of drugs. Using examples, outline the advantages and disadvantages of transdermal drug administration. And I consider this an intermediate question. Initially, you sort of think, well, perhaps it's going to be an easy question because of the application of Fick's law of diffusion. But I think that, having to use examples and then discussing the advantages and disadvantages really adds another layer of complexity. And it's no surprise that when you do look at the repeat pass rate, so it was set in 2018, had a pass rate of 33%. And the learning objectives that is associated with this is BTGS 1.8, describe absorption and factors that will influence it with reference to clinically utilized sites of administration. This is the 1-minute structure from the candidate here. So we've got occurs via diffusion, Fick's law, so that's excellent. And then after that, they go to talk about the factors that would be associated with Fick's law of diffusion. So things that would affect the drug, the administration, patient factors, which I think he's going to write over here. So patient factors, and this must be the this must be the administration, I think, and something along. I can't decipher that, but the core structure here would be based around Fick's law of diffusion. Right. ADs, sorry, these are advantages. So advantages. So and then the D would be the disadvantages. And I think that would be the way to set out a question like this. And I encourage you to practice advantage and disadvantages questions. They're actually quite difficult, especially if you haven't done them before. My suggestion for the format is to always think about it in terms of, one factor versus another factor. So in other words, here would be the advantage of transdermal application versus oral administration. And that's where that would be one heading. And then after that, list all the advantages of that. And then after that, the disadvantages of transdermal drug administration versus oral administration. Because in that way, you actually separate your concepts and describe it clearly. Because otherwise, what often happens is that you often talk about the advantages of one and then the disadvantages of another. And it just lacks that coherency. And so this is a really sort of good question to sort of practice on and try to figure out a format which presents itself really well. Okay. Now, this is the third question. Compare and contrast the effects of the right lateral position, right side down, on lung ventilation and perfusion in a healthy 70-kilogram patient who is A, awake breathing spontaneously, or B, anaesthetised, paralysed with IPPV. This is a difficult question. The reason for that is that if you look at it, it was a repeat with a 9.1% pass rate. I do cover this. For all those who've just recently joined, I do cover this in episode 11. So it's under respiratory physiology, ventilation, perfusion, relationships. And hopefully for all the trainees that saw that episode, hopefully this will be a lot better answered. The learning objective associated with this is ITGS 1.9. So outline the physiological changes that occur with and the implications for anesthetic management of the following patient positions: supine, Trendelenburg and reverse Trendelenburg, lateral, lithotomy, and prone. And I must say, I was hedging that prone would have been a question that would have been asked for this exam, just given, our recent experiences with COVID and proning patients, but maybe one for the future, maybe one after this lateral question is improved on in terms of its answer. This is the 1 minute structure from this candidate here. So very nice. Again, sort of they've defined what, and I think this is really important, define what dependent and non-dependent is. So they've said that the right side is now your dependent lung, which is the base, and the left lung is your non-dependent lung, which is the apex. Okay, represents the apex, and they've got their numbers here. And you know, the way that I think about it is the rule of sevens. So once you've got what normal is, you can just use the rule of sevens to determine how ventilation changes in the lateral position. Okay, both in terms of the awake patient and then also the anaesthetised patient as well. They've got a compliance curve, the idea about what happens with perfusion, with ventilation, and also with VQ mismatch as well. This is probably the most difficult question here. I never thought that this would come up in a short answer question. I always thought this would be a Viva question, but there you go. They've made this into a short answer question. So it's draw and label a graph of a normal basic viscoelastic test of clotting function. What information about the physiology of clotting is depicted in this graph? How will the graph be altered by hyperfibrinolysis? And hopefully, you know, this is something that is becoming more prevalent in terms of our use in anesthesia, especially in obstetrics, and that, you know, you guys get to experience how to actually use and also interpret these graphs as well. And that will help you understand a lot of the key concepts here. Now, this is a new question. So one of the 4 new questions out there. The learning objectives is based on BTPO 1.114, which is outline the methods for assessing coagulation, platelet function, and fibrinolysis. And this is the 1 minute structure. So yes, the key thing would be to actually have the diagram out and have all the important points here. So the R time, K time, alpha angle, maximum amplitude, lysis 30, lysis 60. And then after that, once you represent that, you can discuss about what each one of those terms represents, and also draw what would happen with hyperfibrinolysis, how it affects your lysis 30 and 60. Question number 5. So this is an intermediate question. On the same axes, draw washing curves for the first 30 minutes. Administration of nitrous oxide, 70% nitrous oxide, 6% Desflurane, 2% Sevoflurane. Explain why the curves are different for each agent. And this was a repeat question. So 2019, so 3 years ago, had a pass rate of 26%. And the additional comment that was there in the repeat, but not here in the new one, was that the previous question had described and explained the effect on these curves with A, a doubling of alveolar ventilation, and B, a doubling of cardiac output. And I think that they probably did this because there's quite a bit to actually answer in the initial question. But I think that a good answer would have the effect of alveolar ventilation and cardiac output and how it affects these curves differently. Excuse me. Now, the variations are from 2017, so outline the factors which influence the time taken for loss of consciousness during an inhalation induction of anesthesia. And also 2003, this was the halothane one. So I think we quickly did a 1 minute structure for this in one of the exercises just about a fortnight ago. And these are the learning objectives. So it's based on BTGS 1.24. And this is quite a big learning objectives: the uptake, distribution, elimination of inhalational anesthetic agents, and the factors which influence induction and recovery from inhalational anesthesia. So the concepts of partition coefficients, concentration effect, and second gas effect. And, really good that this learning objectives actually tells you about the key concepts that you need to put in your answer. Relationships between inhaled and alveolar concentration and significance of the distribution of cardiac output and tissue partition coefficients on uptake and distribution of volatile agents. Let's have a look at the 1 minute structure. So very good. They've got the idea about the concentration effect plus the solubility, and they've got what the curve would approximately look like and the determinants of washing. And this one here, so they've got a mnemonic here, and T is going to be the time constant for washing. So I think this would be the time constant of the circuit. And I would be the inspired concentration. V is probably the alveolar ventilation to FRC ratio here. Okay, and after that, you've got the solubility, the alveolar partial pressure, and is that to do with cardiac output, or is that probably to do with the tissue uptake? This is going to be the time constant with regards to tissue uptake. So that's a function of both the solubility of the agent as well as the cardiac output to the tissues. And then the last one is going to be shunt. Okay, very good. So this, these 1 minute structures or key objectives are really powerful to really get some, the core concepts down for your answers. Question 6, using a label diagram, describe how a self-inflating bag valve mask resuscitation device works. This will be an intermediate question. It's one of those questions I think that if you know it well, it can be an easy answer, but it's one of those questions where I think it's either you know it well or you sort of have to do a bit of guesswork on it, which is no surprise. The last time that was asked in 2020 had a pass rate of 35%. And the learning objective is BTSQ 1.13, describe and classify breathing systems used in anesthesia, evaluate their clinical utility and hazards associated with their use. This is the 1 minute structure from the candidate. So we've got the reservoir bag, we've got the APL valve here, and after that, you've got the bag, which allows you to pressurize, and then this is the mask, and this would be and you can actually apply PEEP around this area here too. So we've got oxygen, self-inflating, one-way valve, FiO2, and then overpressure, 30 centimeters of water. Excellent. So they've got the diagram, and then after that, they've got the concepts which they want to talk about for this self-inflating bag here. And these would be the pros, and this would be the cons. Excellent. And, with a self-inflating bag valve mask, they would be considered a Mapleson C circuit. And I will go through in a future session how to think about Mapleson circuits. It is quite commonly asked in Vivas, but because I think this question is asked already, probably unlikely that a Mapleson circuit will be asked again for this Viva. Question 7, discuss the potential adverse effects of suxamethonium. Very core topic, and hopefully everyone should be able to get a really good answer out of this. And no surprise that it's a repeat question. So that last repeated 2019 with a 46% pass rate and 2017 with a 54% pass rate. And you might say that's quite low, and probably is, because I think the easier the question is, probably the more detail you actually need to put down to get that 3 out of 5. Okay. So the learning objective here, 1.38, describe the adverse effects of neuromuscular blocking agents and factors that may modify responses to muscle relaxants. And here, very sort of nice, easy structure, where the adverse effects can be divided into cardiovascular, histamine, malignant hypothermia, apnea, hyperkalemia, spasms or myalgias, increase intraocular pressure or ICP, and anaphylaxis as well. So 1, 2, 3, 4, 5, 6, 7, 8. So 8 points of discussion at least. And then after that, you sort of expand on each concept as well. So really good breadth there. And then after that, what the time will be spent on getting depth for each of these points here. 8th question, compare and contrast the pharmacology of ephedrine and norepinephrine or noradrenaline. This will be considered hopefully a relatively straightforward question. And it has been asked before in 2017 with a 61% pass rate. So the learning objective here is that it's based on BTPO 1.53, describe the pharmacology and clinical application of adrenergic agonists. And then the secondary ones are 1.52, describe the mechanism of action and effects of sympathomimetics and anticholinergic drugs used clinically. So we'll have a look at the 1-minute structure here. And what they've done is they've put ephedrine and noradrenaline. And I think that when you've got a compare and contrast the pharmacology, so there's a couple of ways to do it. You can consider a table and sort of list all the ideas for ephedrine on one column and all the ideas about noradrenaline on another column. And the other way to do it is to do each idea as a paragraph, so that what you do is let's think about it in terms of the pharmacoceutics of it, and that you could say that with the pharmaceutics, ephedrine is a non-catecholamine, whereas noradrenaline is a endogenous catecholamine. Look, the downside of doing that is that you have to repeat ephedrine and noradrenaline multiple times throughout this discussion. But the advantage of that is that you are actually compare and contrasting it. Okay, I think one of the key things is that sometimes when you write a table, it doesn't come across that you're comparing and contrasting. What it comes across is that you're just writing down facts in a table, so that you have, if you do decide to do it in a column format, make sure that you do it in such a way where it does appear to the examiner you are compare and contrasting it. And I think, an idea would be to perhaps discuss ephedrine in here, and then after that, just compare or state what the difference is with noradrenaline. So I think that would be the way to go in terms of the structure and format for this question here. I always find the most challenging questions in the SAQs are always the compare and contrast and the advantage and disadvantage questions. And the reason for that is that everyone just always heads to a table. And I think that when you practice doing a table on the official exam paper, you will realize how difficult it is to represent ideas across in a table. So I think that, if you do want to do a question in table, and it is possible, make sure that you practice the format and the way that you do your wordings of the question, of your answer, and that it comes across so that it actually, applies in terms of what it's trying to answering, from the question. Okay, so that would be my sort of tip, is that make sure that you do practice doing these compare and contrast questions. Question 9, discuss the physiological responses to administration of 2 liters of Hartmann's solutions intravenously over 1 hour to a conscious, healthy, euvolemic 70-kilogram patient. This would be a straightforward question, and you might sort of say, "Ooh, this might be quite tricky." But hopefully, if you looked at the exams report from 2019, they've actually got a really good structure for this answer. So they've got a pass rate of 44%. And this is based on ITGS 1.5, which describes the chemical composition of crystalloids and colloids used in clinical practice and their effects when used in volume replacement. And this would be the structure here. So make sure that you know what the components of Hartmann solutions is. Its volume effects, so both in terms of cardiovascular and renal, its effects on osmolality, its probably its fluid shifts, and then after that, its half-life, distribution half-life in terms of the vascular system. So it's around sort of 30 minutes. Okay, and then its effects on acid base and temperature. So really good breadth of ideas here in this sort of 1-minute structure, key objectives. Good stuff. Question 10, describe the pharmacology of midazolam relevant to its use for pre-medication. This would be considered, I think, an intermediate difficulty question. And it is a variation of an old question, so that the previous iterations of this question have just been described the pharmacology of midazolam. But now this is very specific to its use for pre-medication. So I think that previously probably it's been thought about in terms of its anti-seizure activity. And now we're just talking about it in terms of its use as a pre-med. So it opens itself up to other ideas, specifically its use orally in pre-medding children as well. Okay, but don't forget to also discuss it in terms of the intravenous use as well. Okay. And this is the learning objectives. So quite a bit here, ITGS 1.1, and then these are all the secondary objectives, which essentially have to do with the pharmaceutics, pharmacokinetics, and pharmacodynamics, and the adverse effects of all our sedative hypnotic agents that we use. So the primary ones that we need to know about are propofol, thiopentone, midazolam, and ketamine. And this is the key structure here. So they've got the idea that it's an imidazole benzodiazepine. It's water soluble and used as a pre-med, and really good, just really core sort of structure in terms of pharmacokinetics, absorption, distribution, metabolism, elimination. And then after that, it's dynamic effects. So it's effects through GABA A. And then after that, you sort of expand on these concepts here. So well done. Question 11, briefly outline the structure and function of the blood-brain barrier. So this is something that Dr. Catherine Davies went through a couple of episodes ago. I think she went through it, episode 19 for those who have just joined. So have a look at that one there for the structure and answer for this question here. The learning objective is based on exactly based on 1.96, which is discuss the significance of the blood-brain barrier. So the only difference is just the changing of the words. So instead of physiological significance, we've got the structure and function, but it's essentially the same idea. And it had a pass rate of 39%. And looking at this 1-minute structure, so we've got the blood-brain barrier, we've got the idea of endothelial podocytes or astrocytes, basement membrane, protein. This must be electrolytes, I think, pH, and must be nutrient release, maybe, and not sure about the last one, what this one is. But yeah, a lot of the sort of the key concepts here to sort of discuss and expand on as well. This is a new question, and you sort of look at it and you go, this is really a core question. But yes, this is the first time this question has been asked. Define cardiac preload and describe its determinants. So this is a new question. The learning objective is based on BTPO 1.45, which is discuss the factors that determine and control cardiac output and the implications for clinical practice. And the ones that we need to know about are preload, afterload, and contractility, the Frank-Starling mechanism, the cardiac output and vascular function curves, and pressure-volume relationships in this curve. And I think that if you read this objective here, the previous question regarding preload, these are some of the key concepts I think that we can include in or should be included in the answer, which is the idea of what the Frank-Starling, the idea of its impact on the cardiac output and vascular function curves, and also the pressure volume relationships as well in the heart. So this question is actually quite complex in that it probably lends itself, I would think, to about almost 4 or 5 graphs, all right, if done sort of really well. And this is the structure here. So we've got the idea about I think this must be the stretch on ventricle. So this talks about the Frank-Starling mechanism, the stretch on the ventricle at the end of diastole, and that also probably describes the definition of preload as well. And then we've got the factors that affect preload. So heart rate, venous return, and probably one more. And I wonder whether that has to do with, so diastolic filling time is heart rate, venous return, and blood volume would be the other one that I can sort of think of that would affect your venous return. There's also venous capacitance as well. So that, and you can derive all this from thinking about it in terms of the vascular function curve. Okay, so that's why if you sort of base your answer on those curves there, you should be able to get out a really good answer and able to describe its determinants. Question 13. This is a hard question. Discuss how the responses to opioid medications are altered in the elderly. Explain using pharmacokinetic and pharmacodynamic principles. I think that this question here, you could probably get a sort of a brief overview, but I think that there are some specific pathophysiological changes that occur which affect the pharmacokinetics and pharmacodynamics of opioids in the elderly, and probably covered in the I would assume, not having read it yet, but probably covered well in the ANZCA pain book. Okay. So this would be the learning objective, BTPM 1.10, which is describe the effect of physiological change and pathological disturbance on the pharmacology of the agents listed in learning outcome BTPM 1.9. So that just basically describes all the analgesic agents with special reference to the elderly. And the secondary objectives are BTPM 1.9 and BTPM 1.8, which is the alterations to physiology and perception of pain in the older patient. So this is quite a broad concept here. Remember that this one is specifically talking about opioid medications, okay? And not just its analgesic effects, but probably its adverse effects too. And that's probably how I would tackle this question here. Let's have a look. And so the way that this candidate is going to tackle it is in terms of very well structured, I think this will be sort of a very core structure to use. And that would be ideas in terms of the changes in terms of their pharmacokinetics, so absorption, distribution, metabolism, and elimination. And then after that, changes in their dynamics. So changes in their sensitivities, in their something, not sure what that is, but and then after that, this would be the variability in response as well. And this one probably has to do with the changes in, must be something to do with the adverse effects and the changes on SpO2 saturations, perhaps. Okay. 14, on the same axes, draw the oxy-haemoglobin dissociation curve for both fetal and adult hemoglobin. Explain why these curves are different and the physiological advantages of these differences. And this is a newly worded question, but it is a repeat. And so it is a variation of the Bohr and Haldane effect, specifically the Bohr effect in terms of transplacental gas exchange. And whenever there's a question asked about the Bohr effect or the Bohr factors affecting diffusion of gas across the placenta, always seems to have a fairly high sort of pass rate. So 31%, 77%, 42%, 50%. So, you know, it would be probably considered, I think, hopefully one of the easier questions to do, because the nice thing about this is that once you sort of draw both the fetal and adult hemoglobin curves, it hopefully sets up a platform in terms of where you can discuss about the reasons why, okay, the fetal hemoglobin is left shifted versus the maternal hemoglobin. And then after that, bring in the discussion about what happens with the double Bohr effect. And I think that would be, you know, that would be a really good way to answer this question well. And, you know, just thinking about it, it actually lends itself quite easily to a very, very nice structure. So diagram first, and then after that, expansion of the ideas on why those curves are different. So based on objective SSOB 1.4, which is describe the uteroplacental circulation and the principles of placental physiology as related to placental gas exchange and regulation of placental blood flow. And we've got the 1 minute structure here. So very nice. They've drawn out the double Bohr effect. And then after that, the effects, you want to hopefully remember the PO2s and the SpO2s for both fetal and maternal, the P50s, and he's going to talk about the double Bohr. And I think probably this will probably be like the hemoglobin structure of HbF versus maternal. And last one, they've ended with a difficult question. So briefly outline the physiology of the hormones produced within or activated by the kidney. Do not discuss autocrine or paracrine substances. In other words, don't need to discuss things like cyclic AMP, adenylate cyclase. So those things are considered autocrine substances. Okay, or even nitric oxide. And this is a new question, as I said before, based on BTPO 1.66, which is outline the endocrine functions of the kidney. And what have we got here? So we've got really sort of key three ideas, which is EPO, renin, and vitamin D. And these would, I think these would be the three sort of main hormones there, specifically renin. Okay, and I think renin would predominate this answer in terms of all the other hormones associated with that. So I would think that, you know, for this answer, about 50 to 60% of your answer should be dedicated to the idea of discussing about renin, angiotensin, aldosterone system or sympathetic activation. So this is a summary of the 2022 A paper. You've got what I consider five straightforward questions, 5 intermediate questions, and 5 difficult questions. And in terms of the topic, so 7 physiology, spanning across cardiovascular, respiratory, coagulation, neurophysiology, fluids and electrolytes, obstetrics, and renal. And 7 pharmacology, so pharmacokinetics, inhalational, IV induction, opioids, neuromuscular blocking drugs, cardiovascular, pharmacology, and anti-emetics, one equipment related to the breathing system. And so you can see that they actually have quite a bit of breadth across this paper. Certainly no repeats within each core topic. And you would say that there is a representation of all sort of the major topics that are listed. So cardiovascular, respiratory, inhalational, IV induction, opioids, neurophysiology, renal, they've all been represented in this exam. And I think there's been a shift towards that. So just, this is quite interesting to note, is that I think that as we move forward, and I'm sure that if I did this to another paper here, another recent paper, you would also find sort of the same sort of spread within that paper in terms of topics. Okay, so hopefully that will sort of give you an idea on, you do need to focus on breadth, okay, with this exam. So as much as cardiovascular, respiratory, inhalational, IV inductions are important, they will get represented probably in the paper, but there'll only probably be one question on that topic. All right. Now, if we think about it in terms of the flow, so in terms of the flow from 1 to 15, we can go from pharmacology, anti-emetics, so that's a straightforward one, to an intermediate pharmacology question, to a difficult physiology question, so respiratory, to another difficult physiology question, coagulation, to an intermediate pharmacology question, to equipment, to another pharmacology question, a physiology question, a pharmacology, physiology, difficult physiology, difficult pharmacology, straightforward physiology, and difficult renal. The reason why I've done it this way is just so you understand the flow of the exam. Okay, so if you decide to go from 1 to 15, which probably most trainees will do, and it's probably the format that I recommend, when you eventually get there in August, you want to train your brain to be able to go from pharmacology to physiology to pharmacology to equipment to pharmacology to physiology, back to pharmacology, back to physiology, back to pharmacology. Because at the moment, a lot of you will be completing your coverage phase, which is very specific to key themes, and that's okay. That's how I recommend you should study. So study it in terms of blocks, but as you sort of progress through, keep one eye on the idea that as you progress further, you want your ability for your mind to be able to flip from one subject to another, okay? And this will come with practice as you sort of approach that revision phase, as you sort of do short answer questions, and you do it in such a format where you go from one topic to another. And you can see here that in terms of difficult questions, physiology will always be, I think, conceptually a lot more challenging than pharmacology, which is why when you look at all the difficult questions, they primarily come from physiology or equipment, and proportionately a lot less in terms of pharmacology. Pharmacology, I think, because they've got very sort of good set structures on how to answer them, they tend to sort of lend themselves to more sort of intermediate in terms of level of difficulty. Okay. So in summary, there were 4 new questions in the 2022 paper. Two of the questions were variation questions, where the last print was 2014 and 2018, and there were 9 repeat questions. So spanning from 2013 to 2020. There was one from 2005, but I've just said that, you can probably include that from the 2016 paper. It really was a variation of, the question there, and that was with regards to anti-emetics. Now, what does that mean for all you guys here today? So the take-home messages are that the exam is a balanced exam, and this is something that I've seen over the last couple of years. So they've got that breadth of topics, and they've also got that spread of difficulty as well, where I think it is probably expected that there will be 5 out of the 15 questions which would be considered difficult, okay? And I think that in terms of planning, what you do is you can say, look, there are 5 questions which are green, which hopefully that you can practice and prepare really well and aim to get a 4 out of 5. There are 5 intermediate questions where your aim is to get somewhere between sort of the 2 to 3 mark. And then after that, there is hard questions where you want to be able to get hopefully a 2. For where you go from here, when you start thinking about your revision phase, review the SAQ papers from the last 10 years. And I think that is quite a safe thing to do, all right? That will mean that you'll cover 300 SAQs, which would represent 70% of the coverage of the paper that you will be sitting in August. So in other words, if you do the last 10 years, 3 out of the 4 questions, you should have covered it somehow by just doing past questions. Now, it's rare, but not impossible. I have seen it a couple of times for a question to be repeated from the last year. In fact, even from the last sitting. Okay, I've seen it. I think I've seen it done once where a question was repeated from the last sitting, and probably just a couple of times where it was repeated from just the year before. But often you can see that most questions will be taken from about two years before up to about the 10th year. Okay, and that would be a very achievable revision plan for you guys to sort of work on when you head to your revision phase in May to June.